There's certainly more visits as well with docetaxel, at least right up front, but it's kind of a short period of time, and then you're done with it. So these are the types of things we do. So when I see a new patient with metastatic hormone-sensitive prostate cancer, this is the first thing I consider. Well, first, I don't treat M0 patients yet. Even though there are M0 patients in the STAMPEDE studies, I don't treat them yet. I don't think it's standard of care yet. The survival benefits, all driven by those that have metastatic disease in all these studies. I treat low-volume disease patients, as I said, with abiraterone. And for high-volume disease, I offer both, either or abiraterone, not both together, I mean, and discuss basically what the patient preferences based on their comorbidities and side effect profiles, duration of therapy, financial toxicity. And what I find in my clinic is about 50-50. Half the patients will take abiraterone, half the patients will take docetaxel. I think there's no data for adding abiraterone many months later for somebody who's had ADT or ADT and docetaxel. This is a very common question. I'll see a patient, they've had ADT and they've had ADT with docetaxel, and they come to me and they're 9 months, 12 months down the road, their PSA is undetectable, and they said, I just heard this data that abiraterone has dramatic survival benefit, maybe I ought to add it now. Not clear, no data. But there are a lot of interesting clinical trials ongoing that are combining the theory of very potent AR-targeted therapies with docetaxel. Piece 3, Titan, Arasense, these are all, they're not all abiraterone, but they're AR-targeted agents like apalutamide, ODM-201, with docetaxel as well. We will eventually get some data on whether the theory of these potent AR-targeted therapies with docetaxel adds additional benefit than one alone. Okay? So we'll wait and see. So here's case 2. This is a 68-year-old patient who received androgen deprivation therapy with abiraterone and prednisone. This is actually the same patient. So the PSA goes undetectable after getting ADT and abiraterone, remains there for another year. Then the PSA begins to rise. He gets enzalutamide in this setting, but the PSA continues to rise, and restaging scans show progressive disease, back pain begins to return. All right, he gets 6 cycles of radium-223, some stability in PSA, then his PSA begins to rise again. After 4 cycles of docetaxel, he suffers from extreme fatigue. He doesn't want chemotherapy anymore, but his ECOG performance test is still 1. His PSA is currently now 58, multiple new liver metastases on restaging scan. What do you do now? Pool T, cabazitaxel and prednisone, metastatic biopsy of a liver metastasis, or hospice. I get to see real-time answers. This is different. Okay. Is this like 3 people that have answered? Really? I'm sort of think it is. All right, fine. We'll just talk about it. Oh, we got another one. Oh, and another. It's 5 now. It can't be 5. I'm kidding. All right. I think you guys are right in the fact that full cell T is not the right answer here. This patient has liver metastases, clearly symptomatic. This is not the right patient for full cell T, which is approved for metastatic asymptomatic patients or minimally symptomatic patients. That's not this patient. Okay. Cabazitaxel and prednisone, that's a fine answer. There's nothing wrong with that answer at all, and it is an FDA-approved agent. But I would like to do number 3, and here's the reason why I'd like to do number 3. This is kind of a bizarre case. There aren't a lot of patients that have visceral metastases or liver metastases in this disease, and it's popped all up. I'd be even more suspicious if the PSA level was 2. All right, so the PSA level is 58. You certainly could do cabazitaxel and prednisone, nothing wrong with that. But I'm always a fan of getting more information, so I would biopsy this patient. There's nothing wrong with hospice as well, is that if that's what the patient wants. With this patient, ECOG's still 1, certainly could undergo further treatment. So what would you look for with a liver, with a metastasis of the liver and liver biopsies? Well, before we talk about that, when would I consider a metastatic biopsy? Somebody with liver mets, somebody with really bulky lymph nodes, somebody with a super low PSA in the setting of high volume disease, and lytic metastases. Usually you get blastic metastases. When I see lytic metastases, I'm always thinking, could there be neuroendocrine prostate cancer? That's in the back of my head. And so I'm looking for small cells on morphology, or I'm looking for neuroendocrine stains, chromogranin A, synaptophysin. So this is rare as a new diagnosis, new de novo presentation, but much more common now in the area of potent AR-targeted therapies like abiraterone and enzalutamide, and certainly now apalutamide. So it's probably arising as a mechanism of resistance to androgen deprivation therapy. And again, if you look on tissue for the immunohistochemical markers, usually chromogranin and synaptophysin, although NSE can also be positive as well. And how do you treat it? Well, you treat it like with platinum doublets, just like small cell lung cancer. So I use etoposide and platinum-based chemotherapy. So that's one thing that I'd be looking for. But here's another thing I'd be looking for, and you guys saw this data, microsatellite instability. Now, why not send off for testing to see whether the patient has any microsatellite instability? Now, really, this is interesting because MSI testing, and this should be considered different in every cancer. And the approval did not state how to test for it, right? I think this has to be standardized in the future, whether you're doing immunohistochemistry for one of the mismatch repair alteration genes, MLH1, MSH2, MSH6, or whether you're doing microsatellite instability testing, or whether you're looking at tumor mutational burden, mutational load. Probably the latter is the most important, but that being said and done, sometimes we'll see patients that even have losses in, let's say, the MSH2 or MSH6, but they don't have microsatellite instability or they don't have hypermutation. I think it's a process in evolution. These Lynch genes are also, not highly penetrant, so you can see patients with a germline alteration that doesn't really express in the tumor. So when you see this, it's quite complicated. You have to test the tumor, and you have to really, really take a look. And how you test for it is different depending upon what tumor type. In colon cancer, it's pretty straightforward. They have 5 loci they look for. In prostate cancer, Collins-Pritchard's assay looks at 18 different loci, so there can be different loci for microsatellite instability. But the point being is if you have this, you're more apt to respond to pembrolizumab. I'm not going to go over this in great detail because Max already went over it. But here's the deal. It happens in prostate cancer. Collins-Pritchard published a study quite a bit ago now. 2014 is quite a bit ago, that showed in our rapid tumor autopsy program it was about 12% of patients. Now, we have a rapid tumor autopsy program where many, many patients have been kind enough to donate their bodies to science for study, and we've learned a lot from it. But we also have to recognize that looking at a patient who's passed away may be different than looking at a real live patient, okay? Somebody with metastatic castration-resistant prostate cancer, when you look up the Stand Up to Cancer metastatic castration-resistant prostate cancer biopsy series that we were part of, it was more like 3%. Now, our studies at our group and Johan de Bono's group in the UK, it looks more like it's around 5 to 10% of patients. But it's common enough to be worth testing for, is the point. And then you ask the question, are there features that we can find that might enrich or increase our yields of finding a hit on microsatellite instability? And this is a paper published by Mike Schweitzer, one of our junior collaborators that we nicely recruited from Hopkins about 4 years ago. And he noticed that patients that had ductal histology, those patients that had ductal histology had a very poor prognosis. And it looks kind of like criboforming of cells, and frankly, it looks a lot like colon cancer under the microscope. So he decided to do UW Oncoplex and do next generation sequencing, and in a very small series found 4 out of 10 that had mismatch repair alterations and responded to pembrolizumab, okay? Now, the one interesting thing about it is the series has gotten a lot larger. We've collaborated with Hopkins and a group up in Canada, and this paper's in press right now, but it looks like half the patients have actionable alterations. Now, that's not P53 or RB. When I say actionable, I'm talking about homologous recombination deficiency or microsatellite mismatch repair alteration genes, and it's about half the patients have something significantly actionable. So this is one trigger to say, maybe if you see ductal histology on your path report with prostate cancer, we should be doing next generation sequencing on those patients. Now, Julie Graf's group at Oregon Health Sciences showed that when you have patients progressing on enzalutamide, that if you add pembrolizumab, about 19-20% will have a dramatic response. And you might say, well, that's not a real high number, but look at these examples. The PSA dramatic decline with just 4 cycles of pembrolizumab, and it's rather durable, the response. So one might ask, how does that happen? There is some data from University of British Columbia. Jennifer Bishop showed that in patients progressing on enzalutamide, the longer duration time you have them on enzalutamide, the higher the PD-L1, PD-L2 expression on circulating dendritic cells. So that might be potentially part of the mechanism here. So this leads us to some ASCO and some recent data. So there was a Keynote 199 study that didn't look at, well, they did, but they didn't present this initially. But this was just patients who were post one line or more of potent AR-targeted therapy like ABI or ENZA, and post-dose Taxol, and then they broke them down in different cohorts and treated them with pembrolizumab. So either you had soft tissue disease and you were PD-L1 high, soft tissue disease and PD-L1 low, or you had bone metastases and nothing measurable. And so they treated these patients, and here's a summary of the data. I'm sorry it's so small, but here's the RECIST data. Some patients responded, not so dramatic. PSA data, similar thing. Here's the more important RECIST summary, which looks like 3, 4, 5% of patients had a response. Not dramatic, but the lay press got a hold of it and interviewed a patient who had also missed microsatellite instability and had a complete response. And I probably had 15 to 20 patients calling me the next day asking to get on this, even though this was technically a negative study with very small response rates. Okay, so I don't think that this is something to just give to anybody post-dose Taxol. Okay, there's certain molecular features that they might need to have. The other thing is prostate cancer is not a real hot mutant tumor. It's more of a cold, bland tumor. It's not a high mutational complexity like, let's say, the carcinogen-exposed tumors like UV light for melanoma, or let's say smoking-induced cancers like non-small cell lung cancer. But